Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jacqueline Meredith. This episode features content from an educational webinar titled Answering the Questions on Which HIV PrEP for Which Patient, featuring Dr. Jill Blumenthal and Dr. Kenric Ware. Dr. Blumenthal is an associate professor of medicine at the University of California, San Diego, and Dr. Ware is a clinical associate professor at the Mercer University College of Pharmacy in Atlanta, Georgia. In this episode, they will answer questions and discuss key considerations when determining PrEP candidacy, choosing among PrEP options, and addressing PrEP persistence for individual patients. For the full online educational program, please visit the link in the show notes for this episode. Now let's get started. We've had a number of questions for our participants, and we'll do our very best to answer as many questions as we can now.
So a question came through that I think would be really good for you, Kenric. If all PrEP options were available on campus or at a nearby location, do you think college students would prefer to take oral or injectable PrEP? And what would be the pros and cons for each?
So great question. So thank you, Jill. I think, so we think college students, if those that are probably more local to the area where they're actually enrolled in school, the injectable PrEP may be an option. One of the challenges becomes, say, if a student were living, states away or maybe in a different country, injectable PrEP would probably be more of a challenge, right? Because it's going to be tough, to adhere to that every 2 months, particularly when we start thinking about over some of the breaks or the different breaks in school. So I think overall, if someone is more confined to the area, injectable PrEP may be an option. I think also what to take in consideration, if college students aren't on as many medications, some students may prefer the oral option because depending upon where they have to go to get the injectable PrEP. So again, transportation may be a barrier, particularly if you're enrolled in a college in more of a rural setting, right? So where do you actually go? And perhaps maybe you don't have a health center at your institution. So then we're thinking about transportation barriers, right? Or even if transportation were not an option, competing with class schedules and perhaps they're athletes and all these things that that we consider on campus. So I think the injectable PrEP is an attractive option for individuals who perhaps are more local. They're not attending school, states away. I think the injectable would be good there. Or if it in a rural area, perhaps I know some organizations will have mobile units where they come and actually transport students to particular appointments. So I think that would be a great option there. So definitely, just ensuring that they continue to be consistent and meet that every 2 month mark. I think injectable would find a bit more favor, but oral options may be more favorable if someone is solely in town for school and is going home quite frequently. Injectable may not be as reliable.
Yeah, I totally agree with everything you said. The way I counsel patients who say, what should I do? I always get the what's better. And I say, what's better is what works best for you, because they both work really well. I sometimes lay it out, do you take other medications? Because if someone takes other medications, they may already have a pretty good routine. And, how do you do with those other medications? Are you good about, do you feel like you take them most days? And if someone says, yeah, that's not, that's pretty easy for me. I think that's a very easy option. I think for someone who's never taken a medication before, the idea of, or, it's rare, they're struggling with their other oral medications, injectable becomes much more attractive. The other thing, and this is assuming that they're local and they can do it, with injectable PrEP, they're coming into the clinic 6 times a year. Whereas with oral PrEP, it's more 3 to 4 times a year. And some people, just those 3 extra visits, even if they're faster because they're just injections, it's too much for some people, and, getting to transportation and all of that. So sometimes I break it down just like that. And, do you think you can come in this frequently for these visits? But knowing that once you leave here, you really don't have to worry about much of anything. You don't have to worry about taking the medication each day. Thanks, Kenric. I don't know if you have anything else you want to add.
No, I think you hit it on the head. I think, again, as you mentioned, if college students are already consistent with their regimens, their oral meds, sometimes it can be a bit of an inconvenience to have to go in, right, for one particular medication if they're taking all the others at the same time of day or at a similar time of day. So I think that continuity is very, very important in making sure that, like, as you mentioned, doing what's best for that particular student.
Yeah. I was just going to ask another question to you, but we can both talk about it, I think. But, talking about the racial ethnic disparities among PrEP uptake, I think they're really important. We know that's driving a lot of health disparities as well. So could you talk about, what are some of the initiatives in place to help address racial ethnic disparities associated with PrEP uptake?
Sure. Thank you. So that's a great question, Jill. And one of the things that we have to keep in mind is how do we get to the campuses and really understand PrEP and PrEP uptake from the perspective of college students? So admittedly, I'm very, very fortunate to be working with a program. It's actually out of Duke University called Evidence to Practice. And the way that works is under the leadership of Dr. KK. I'm working with Russell Campbell as well from the HIV/AIDS Network Coordination. And what we do is we go, a group of us, a team of us go onto campuses and actually try to help our college students to see PrEP through their lenses, right? So we started, as you mentioned a little bit earlier, in the South, in South Carolina specifically, we've been very, very intentional about going to historically Black colleges and universities in South Carolina, because if you're familiar with the HIV epidemic, South Carolina is one of those priority areas where there's been quite a bit of attention drawn to the South, and particularly in our interest in South Carolina, is going on campuses, asking students to envision PrEP. How would they raise awareness of it on their campuses? Where would they go to get PrEP in their local context? And so I think those are some of the things that we found some favor with. We're also looking to expand some of that work into pharmacy schools and other locations as well. So I think anything that's really centered on campus where students can actually customize PrEP uptake in their area, because there's a really big difference in a college that's in a rural location, a very rural location, versus a college that's in a more urban area with more resources, more opportunities, more touch points. And so I think really having students to see their local context and what are some options that are available to them has been pretty helpful. But it's definitely not a one size fits all. I want to definitely say that. I mean, when we think of college campuses, the culture, the locations, all those things really, really matter when we think about how do we get, students to, particularly students who are disproportionately impacted, right? As we talked about earlier, how do we really get them to see that PrEP is for them, or it could be for them, it could be a viable option for them. Like, what do we do? And some of that is really just trusting their context expertise, right? So them being the experts on whatever context they live in and really trying to guide implementation based upon that.
No, that's great work that you're doing. We're doing something similar-ish here, sort of trying to get peers, people who are either PrEP or ART experienced, to be peer educators, people with experience in the health system doing this. You are the content expert. Can you talk to your other peers, young people, about it and about your experiences, in the hopes that can help attract people and to learning more about PrEP and being taking it more into consideration, because we know that young people are still one of the biggest hit areas in terms of HIV incidence, and need to keep doing this work as best as we can.
Okay, great. So Jill, I know we talked some about the adolescent side of things, and so also here, and this is a question that I've actually encountered in practice, but I definitely would love to hear your insights on 2-on-1. And you spoke about that on demand and about transgender individuals on gender-affirming hormone therapies, on hormone treatments. What are your thoughts there, right? Because there are some different opinions about it, about, the evidence is still evolving. So I would love to hear from you about what would you say to the transgender individual who's looking, who's heard about on demand or 2-on-1, is looking to get started? What would be your approach?
Yeah, no, this is a great question. And it does come up. I think you've sort of answered some of it, is that the data is evolving, but I think it's evolved to the point where we now have several studies that show there is no bidirectional clinical effect on hormones or on PrEP, sort of in either direction. Our group presented at CROI last year, a large cohort of people where we didn't see any effect on PrEP concentrations or on estrogen or testosterone concentrations. And there have been other studies that have shown that. And as a result of some of this data, and I alluded to this, the IASUSA and WHO actually made some recommendations where it could be a discussion with patients about whether 2-on-1 would work, in the setting of someone taking hormones. That's basically what I tell patients is that this is the data that we know. We know that it definitely works best the more that you take it, or the closer you are to daily. However, there is some thought that doing it around the event could work. We don't know for sure, and it's not been studied the way that it was done in the Ipergay study. We don't have that same data for transgender individuals taking hormones, but because of all of this other data and then some pharmacokinetic applications, I think there's stronger confidence that it would work just as well. But I think these are conversations that, a provider needs to have with a patient and explain that the data isn't as strong as taking it close to daily, which we do have much more data on. But I think for PrEP, and just like a lot of things, this needs to be patient-centered. So I try to approach this of, what do you think is going to work best for you? Do you think you'll be able to do a 2-on-1 regimen? Because I've talked to a lot of patients about that who think that's actually harder because they're like, how do I remember when to take it? But if that's something you really feel like you can do, and maybe you're not having sex as frequently, so the on-demand approach works better for you, I think it's very reasonable to consider it in all populations. I guess with the exception that I still don't feel super confident with is individuals having sex primarily, through vaginal intercourse. Although again, even with them, I'd say if this is someone who says to you, this is the only way I can take it, I can only do it this way, I'm going to take it when I can. I'm definitely I'd like to see people trying to take it. I know you started to talk about some of the resistance mutations, and I don't want to downplay any resistance mutations that evolve or that could evolve. But we now have such wonderful HIV regimens that even if you have some resistance mutations, even an INSTI mutation, you're still going to be on a regimen that works very well. So take that for what that is. I think I'm a little bit more liberal than some other providers. I want patients to do what feels best for them. I try to give them, the information about here's what we know works best, but it has to be what's going to work best for you. I hope that answers the question.
It does. Thank you so much, Jill. And I'm just looking here at the Q&A box, and a question came in from Amelia. I would like for you to maybe take a stab at this one too, Jill, as far as what do you feel is the best approach to assess readiness to take PrEP in adolescents? So I know we talked some about adolescents and some of the work that's been done on campuses, but that was really more at the collegiate level. So what say you there, Jill? Like, how would you, in some of your approaches to adolescents, like how do you assess readiness? So thank you for that, Amelia.
It's a great question. And I tend to see patients who are already coming in sort of already their interest is piqued about PrEP for some reason or another. So I'm taking this from the baseline or from a baseline of at least some interest. And I think it's really just trying to understand, why they want to take it, what they think it's going to do for them. And certainly with young people, making sure that they're not using it sort of for that there are any misconceptions around it. For example, well, this is a tricky one. And I'd be curious, Kenric, to hear how you might approach this, but someone who may be only engaging in oral sex really isn't necessarily a candidate for PrEP. However, we know that oral sex doesn't stay forever, and people often, elevate, change those behaviors over time. So making sure that people are aware of what the reason for taking PrEP is. And then, yeah, is it something that you feel like you could take every day or most days? How do you do with medications? I think we'll sort of weave into a couple of questions. There was something from James about parental consent and age limits. So I'm going to bring you in for that. But, just do your parents know that this is something you're going to be doing? Is it something that you can have open and out, or are you going to be doing it in a more secretive way? And those are my initial thoughts. What about you? What do you think about in terms of adolescents and their readiness?
So great comments. And I think that another key is just really creating, we talked about this some, but creating a non-judgmental environment where we kind of say, hey, how are you really having sex, right? I mean, what can we do to really get to the underlying reason why you're here? Like you said, I mean, if you're asking questions, it is some level of curiosity. So I think it may seem rudimentary, but really ensuring that people are being honest, right? They're telling you the truth about how they're having sex. And once they begin to do that, in my experience, then we kind of have a conversation, okay, based upon how often you're having sex, who you're having sex with, whether you're using condoms or not, or you're using them consistently. I think the readiness piece somewhat, maybe I've just been very fortunate, but kind of situates itself because they're hearing themselves say out loud, these are some of the things, and in a non-judgmental space, right? So I really think it goes back to that point that was embedded in the slides, is how do we create that environment where people can be honest? Because it's really no point in really trying to assess readiness, so to speak, if people aren't being completely honest, if they don't feel they can be honest with you in the conversation they're having. So that's how I've started. And then I repeat back what I hear. And we just kind of make sure that there are no misunderstandings. And then we get into some of the options and say, well, okay, this may be a better option in this particular situation. It was a question that came up. Kevin mentioned about, I see here in the chat, about cost being a concern as far as, oral PrEP with the different formulations. How do we handle that? What do we do around cost? And so again, that's really looking more at having those conversations. Are you on your parents' insurance? Would you need assistance getting this covered? Just ensuring to his question, making sure that there are no lapses in the care and in the adherence based upon cost. And so I think, but honestly, that's a part of readiness as well, in my view, because if it's going to be a barrier that adolescent foresees down the road, with not being able to have that continuity of care, right? Perhaps that's something we proactively address, right? Making sure that cost doesn't become a barrier to the best of our ability down the road, right? So I feel like that's another component of readiness, because the last thing we want is someone to be energetic and excited about taking it, and then cost becomes an issue where they go without it for a period of time. Then unfortunately, perhaps they seroconvert, and it's just a lot of factors there, right? So I think looking at cost proactively is an aspect of readiness as well.
Yeah, thanks, Kenric. And I'm just keeping an eye on the time. There were a couple of questions that I think sort of led into this that I alluded to. One was about the age limit to use PrEP, because this probably goes into a little bit in terms of assessing readiness. I believe the studies, it was studied only as young as 15 for both cabotegravir and TDF-FTC. But at least I know in California, our PrEP assistance program serves people 12 years of age and up. So I would feel comfortable, offering PrEP to someone above that age, as long as they're above the 35 kilograms. Help me out with that. Is that right? 35 kilograms.
Yeah, 7,000.
Yeah. So there really isn't an age limit. I guess I would say it's really more weight based, to answer your question, Nicole. And then the parental consent is a little bit trickier. And I don't know if Kenric, how much experience you've had with that. And if it's something that you want to talk about, I can dip my toe in after, but I think this might be one of our last questions.
Sure. Admitted I haven't had a ton of experience with parental consent as far as like when someone's coming in for PrEP. I think the extent of my involvement there has been more so ensuring that if they want the parent to know, if the parent's supportive, do they feel that they would need to hide it from the parent or guardian? So that's really been the extent of my experience, and not as much consent as it is transparency around, is this something that you want your parent to know about?
Right. And I think that's really important. That's usually how we focus it. It's not necessarily. So I think the answer is that it's state by state. So every state has a different approach to this. Again, I know in California where it's much more liberal in terms of consent about requiring it or not. But I think most of us start with the conversation of, is this something that, you want your parents to be aware of? Do you think they could be a support for you on this? And we know that there's been data to show that people who get that support, the outcomes frequently are better in a variety of arenas. So I agree. That's more of it. Parental consent does come up. Again, it would be state by state when it's actually needed. And unfortunately, in a lot of the southern states, it's stricter. I can't speak to it state by state, but it is important to get a sense of, what those laws are in your particular state so that you can approach it appropriately for each patient. We got a bunch of questions about pregnancy. And I just really quickly, there was one question from Michelle about TAF-FTC and safety in pregnancy. And while it hasn't been studied specifically for PrEP, we know that it's been studied somewhat extensively in people living with HIV, and it's been safe. So there's no reason to think that it would be any different. Sorry, I just wanted to make sure I saw that. I always think pregnancy is sort of important ones to make sure we get those answered. Kenric, were there any other questions you thought we could tackle at the end?
I think the only other one was kind of along the same lines as far as, have you seen any progress? So this was from Venetia about, have you seen any progress or studies with OBGYNs and discussing PrEP with cisgender women, or considerations in targeting specifically around cisgender women? And so I guess from my perspective, with OB, I have had, and maybe I'm just the benefit of good fortune there with some of the OBs I'm working with, I've collaborated with, they are increasing those conversations around the benefit of PrEP in cisgender women. So I've seen some progress in that respect, where it's been more of a part of the routine visit, right? They're normalizing the conversation around PrEP. So I've had some encouraging results there. What about you, Jill? Have you seen that in your practice?
Yeah, I mean, it's definitely an area I still wish we could do more with. And I know there are lots of studies. I think most of them they're taking place more in the southern United States. So I'm a little bit left out of it, but it's been a strong interest of ours. One thing that we're doing, and people who work in academic institutions, we're having all the OBGYN trainees come through our PrEP clinic so they can learn about how to do it, how to have conversations about it, and how to just integrate it. I think also with the new CDC guidelines saying anyone that's sexually active should be made aware of PrEP, I think that's been very powerful, that it's something that they, even if they don't want to go into it more, and I think what we've created, at least at our institution, is a way that they can bring up the topic, but then pass it on to someone else if they don't feel like they have the time, is to just make sure that they're bringing it up. They have some basic knowledge about it, and then they know either where they can do a warm handoff or they actually can prescribe it. And, Kenric, I don't know about you, but I find PrEP to be pretty easy to prescribe. It's not like diabetes medications or the different antihypertensives. There aren't a lot of options, and the monitoring is actually very easy. So, when people say, I just don't have time, or it's too hard for me, especially with an OBGYN who may be prescribing, contraceptives, I say it's sort of, you're just going to combine them and maybe do a little bit of additional lab monitoring that you might not. So I think we're seeing some encouraging changes. I don't know if there's been any data because, the CDC change happened so recently, but I think we'll keep an eye out for that and what that looks like for cisgender women.
Very much to Doctors Blumenthal and Ware, and thank you to our listeners for joining in. Please be sure to check back for more episodes on important infectious disease topics. Thank you and have a great day.